بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي الطلبة، نلتقي من جديد في محاضرة جديدة من سلسلة محاضرات Ophthalmology Made Easy. And as introductory phrases, we used to say that this lecture is mainly targeting postgraduate students who are willing to appear in the FRCS exam or in the Libyan board exam, or also those junior doctors who are practicing ophthalmology in different eye departments and different eye hospitals. The aim is to explore and highlight some and share with you some of the important informations regarding this newly emerging technology that is bridging the gap between the clinical examination and the histopathology. As you know, the optical coherence tomography, also known as the optical sectioning of the eye, because we can see the ultra structures of the eye based on this technology. So beyond the slit lamp that we used to use the slit lamp for a long time for optical sectioning of the eye with this limited resolution, now we shift to the high resolution microscopic quality. That's the optical coherence tomography. So we will divide our discussion to about 3 sessions. Let me remind you first that we will speak mainly on anterior segment OCT. We will not speak about the posterior segment OCT because we have spoken about it before. Now I will elaborate more on the anterior segment OCT. We will speak about the basic principles of this technology, and we will come across certain important terms and definitions that you should be aware of it. As a postgraduate student, you might be exposed to an question regarding these definitions, like the axial magnification or the axial resolution and the lateral resolution and the different scans that's available in this machine. And the second session will be some clinical examples and the clinical applications of this technology. And finally, we must speak about the newly evolving technology that combines the sham flock technology along with the anterior segment OCT, this hybrid technology, which is known as the pentacam anterior segment OCT. We have to speak about it so that we will complete the whole information about this technology and provide the advantage and the disadvantage of each technology, so that you will be aware when you are requested to make an order for a machine. You should be know what's the advantage of the, for example, the swept source anterior segment OCT from the Spectral-Domain anterior segment OCT, or the use of pentacam anterior segment OCT. Now, for you as a doctor, apart from your clinical skills, you should be aware of these specifications and the pros and cons for these technologies, and you should cope up with this rapidly emerging technology so that you will be mastering these techniques and you will be updated with what's the advantage and what's available, so that you can explore more and examine the eye in more details. So let's dive deeply and see what's inside these lectures. We'll start with this first lecture, which provide the fundamental principles of the anterior segment OCT and provide certain basic principles about this technology. And newly emerging question: is there any competition between the anterior segment OCT and the sham flock technology as far as the corneal optical sectioning? Does this OCT or this technology will replace the pentacam, or we can combine them together to achieve the utmost gold standard technology for exploring the details, the fine microscopic anatomy of the cornea? So let's dive deeply, and looking forward to hear your comments about this lecture and your inquiry, and I hope that you will get benefit from this lecture. Quick overview for the content of this lecture. We will speak about some of the historical evolution of the OCT from posterior segment to anterior segment, and then we will provide some fundamental physics regarding the meaning of low coherence interferometry and about the Michelson's interferometry, and also will provide some technical parameters like axial and lateral resolution and scanning depth and penetration. and we will provide information about the clinical application, but this we will make a separate lecture for the clinical applications, so that we will not make this lecture long. So for the clinical application of the anterior segment, we will provide separate lecture for it. And then we will speak about the combination or the synergy technology or combination technology, the use of anterior segment OCT with other technologies like Placido's disc or Pentacam. And finally, we will speak about the future prospect of the anterior segment OCT as alternative to slit lamp, and the role of the doctors in the era of advanced high resolution imaging in the diagnosis as well as in the interventions. So the aim of this lecture is to provide overall view about the significance and the importance of the anterior segment OCT in the clinical diagnosis as well as in the intervention. So by the end of this lecture, you will be able to know why the anterior segment OCT provide a clearer image for the posterior cornea as compared to the Placido's disc or other reflective-based tomography. Also, you will know what's the meaning of trade-off, that you trade off for the resolution for the sake of penetration, or the penetration for the sake of resolutions in spectral domain and swept source OCT. You will understand the meaning of hybrid integration or hybrid technology. That's you integrate both OCT with reflective-based tomography or with scattered-based sham flow technology together. What's the advantage, the pros and cons for each one, and what's the reason for these combinations. And you will know the recent gold standard for the glaucoma, for the keratoconus screening. That's the combination of sham flow technology with the OCT. That's the Pentacam corneal OCT. And you will know also different terminologies like the meaning of primary, or the meaning of axial and lateral or transverse resolution, and so on. So concentrate in this lecture. So these are very important informations. You will need to memorize them. Perhaps anybody will ask you about this information. About the historical evolution of the anterior segment OCT, initially it started as a posterior segment. The optical coherence tomography started initially targeting the posterior segment of the eye. And then later on, the evolution and the transition happens so that it converts to the anterior segment. So the initial genesis start at around 1990s for, as I said, the posterior segment OCT as time domain, and then to spectral domain OCT. Then at 2000s, they start the first FDA approval for the anterior segment OCT. And then final evolution and refinement for this technology by the emergence of the swept source technology. So the anterior segment OCT incorporate the swept source technology in this technology. So these are the main milestones in the genesis of the anterior segment OCT, from the first innovation at 1990s as a posterior segment OCT. Then at around 2000, the first OCT appears as a prototype. Then the first FDA approved was by the Carl Zeiss, the Visanti anterior segment OCT. This is the first FDA approved anterior segment from a Carl Zeiss company. And then a final revolution happens, and the incorporation of the swept source OCT around 2008 by Cassia from Tommy company. So this is the different important milestones and the evolution of this technology and the changes in the wavelength of the light source and the bandwidth used in this technique, so that reaching to the very high axial resolution along with lateral or transverse resolution. Now I will provide a quick comparison between the three main systems of OCT. That's the time domain, spectral domain, and swept source OCT. The first thing, the difference is the wavelength. Now the wavelength of the light source it plays an important role in the penetration of the tissues, so that, as you can see, the swept source has a very good penetration because it uses a wavelength between 1310, same like the time domain. However, the spectral domain uses a lesser wavelength. That's why it has poorer penetration. You can see the penetration in the time domain and the swept source is around 6 millimeter to the tissue, It means that good penetration for the opaque tissues, the sclera, the iris, and the scleral spur. So you can see that achieving by time domain 95% to 100% penetrations, and nearly 100% penetration to the in the swept source, but only 65 to 75% in the time in the spectral domain. So this is one of the disadvantages of the spectral domain, is the use of shorter wavelength, so that it has poorer penetration. However, the use of this shorter wavelength and another advantage of the spectral domain is the resolution. The resolution is spectral domain. The axial resolution is very high, between 5 to 10 microns, and it is roughly around 10 microns in the swept source, and very poor. Now this figure, the more this figure, it means poor resolution, and the smaller this figure, the better resolution. So you can see that the spectral domain has the utmost resolution in the spectral domain. And this is named as a trade-off, that you have to trade off the resolution for the sake of penetration, or you trade off the penetration for the sake of resolution. Trade-off means that you compromise, that you sacrifice for one option for the sake for the other option, that you sacrifice for the good penetration as seen in the swept source OCT, but you have a little bit reduced the resolution as compared to the spectral domain OCT. The other thing is the speed, of course. Now, the evolution of the speed, you can see that the time domain is very slow, and the spectral domain is high speed, between 26,000 to 70,000 scans per second, and the most fast available OCT so far is the swept source, between 50,000 to 100,000 OCT. And now what's the application of this high speed? Number one, the high speed provides you a very meticulous scanning of the retina, regardless of the microsaccades of the eye movement of the patients, even with minor movement of the involuntary microsaccades of the eye. Because of the high speed, you will have very high resolution image. This is number one. Number two, the high speed will cope with the speed of the blood cells and the blood vessels. That's why most of the OCT angio blood vessels are swept source OCT, because of the high speed. So that by contrast decorrelation, they can determine the flow inside the blood vessels based on this high speed. So the speed is very important options. Now, when we speak about the OCT, there are three variables are very important: the speed, the resolution, and the penetrations. We have to ask what penetrations and what speed you have and what's the resolution. And the resolution, we have two types, the axial and lateral resolution. We will come to this later on. So this is example of the available in the market Byzanti time domain, Spectralis, and Cyrus spectral domain, and Cassia 1 and Anterior is the swept source. Now, they, as I said before, that you have to compromise one option for the other, because you know that, for example, the swept source, it has very high speed with a very high penetration, but poorer resolution as compared to the spectral domain OCT. This curve shows the evolution of the speed. As you can see here, the speed becomes very fast in the third generations. Now we are in the era of the third generations OCT. That's the swept source OCT, which provide very fast, very high speed, very excellent resolution, and very excellent penetrations. So this is just a brief comparison between the three systems available in the market. Now, in the next discussions, we will dive deeply to the more fundamental physics of the OCT, or in another word, we can say the optics of the OCT. And this is very important, because for you as a postgraduate, you are eligible to be asked in the exam. For example, I can ask you what's the difference between the spectral domain and the swept source, and what's the meaning of axial resolutions or lateral or transverse resolutions. What's the difference between A scan, B scan, C scan, or the in-face scanning, and what's the effect of the different wavelengths in the quality of the image that you are taking by the OCT. Also the principle of Michelson's interferometer, and so on. So don't think that this is just luxury information that you shouldn't know, but for you as a technician that you are using this machine, or for you as a doctor or as a student that you are going to appear in the exam, This is the basic principles or the physics of the OCT. You should know them and understand the difference between the different terminology. So this is your duty to understand the difference between these two different definitions. Now we will speak on one of the main important principles of physics of the optical coherence tomography, which is about the light source. Now, what makes differ the OCT differs than the ultrasound or other any imaging machine is the light source. Now, the light source in the OCT is known as burst light or low coherence light. This is a low coherence light. What's the meaning of low coherence light? That they use not a regular pulsed light, but it uses a light with a small burst. Now this is a small burst, that it is the pulses, the waves propagate synchronized for a short distance, then it will decay. This is the main important point in OCT. Now this is the regular continuous light. As you can see, this is what you can see in the standard laser beam. This is called high coherence light. High coherence light, it will propagate for kilometers. They make it resemble like a soldier that they propagate in phase, all of them. They will continue to perfectly disciplined machine. They will propagate for long distance. In OCT, we don't use this light. In OCT, we use this light. That's low coherence. What's meant by low coherence? That small burst or packet of pulse will propagate synchronized for short distance and then will decay. Now this distance is called the coherence length. This is the coherence length. Okay, this is the ruler that we use, how we compare one machine with other machine based on this coherence length. Okay, so this is a small burst or packet of light. This is a small burst or bucket of light, and this is a small burst of bucket of light. They make example here that as if you have plenty of people and everybody is going in one direction. So after a few minutes, you will not find anybody here. So this is the area where they are synchronized and crowded here at between 2 to 15 microns. So this pulse will propagate for 2 to 15 microns, then will disappear. However, this pulse will propagate for kilometers. This is should be very clear, because this is the principle of the meaning of low coherence and how the signal of the image will be formed based on this principle. Now, if we look to the Michelson's interferometer, which is present in the OCT, as you know, the difference between one machine and other machine based on the light source. Now, this is the light source. As we said before, that in spectral domain OCT, we use a superluminant diodes to provide this burst of lights, or in the swept source OCT, we use the fine-tuned laser to provide this packet of pulse of burst of light. Okay. Now, once they are emitted from the light source, they will face the beam splitter. Now, this beam splitter will divide 50% will goes to the reference arm or the mirror, and another 50% will goes to the sample, that's the eye. Whatever, if you are focusing in the cornea or in the retina, something, whatever you want to take the image. So this burst of light will goes to the mirror, and the other 50% will goes to the sample, and then of course there will be reflected back. Now the same burst, they will be reflected back from each one of them, and then they come and picked up by the detector. Now the detector here is the factory where the signal of the image is formed. Now, there are some certain rules for the signal of the image to be formed. Number one, if both the reflected packet of pulse from the sample arm and the reference arm, they are propagated in phase, in the same steps like this one, so there will be constructive interference, and this will provide high quality image. Okay. Now, if the reflected packet of pulse from the reference arm or the sample arm, they are not in phase. So there is some delay. As you can see here, there is delay between this pulse and this pulse, but still this delay is shorter than the coherence length. Shorter than this coherence length, still we will have constructive interference, and also a signal for the image will be formed. Now, the third condition, that if the delay between the reflected packet of pulse from the reference arm and the sample, the delay is more than this coherence length, at that time there will be destructive interference and there will be no image formation. Now let's come and decode this more in details and explain as you can see here. Now this is one reflected bucket of pulse from the reference arm, and this is the bucket of pulse from the sample arm. As you can see here, the difference, this is the difference between the delay between this bucket of pulse and this bucket of pulse is more than the coherence length. This is the coherence length. So here there will be no image formation because this will be destructive interference. There will be no constructive interference. So there will be no image formation. The other example now, if the both pulses they are exactly synchronized, or there is some delay but it is still shorter than the coherence length of each burst, so at that time constructive interference still can be formed and the image will be formed. This should be clear. For you as a student, you should memorize this. That's for the image to be formed, or the signal for the image to be formed, either the two reflected bucket of pulses from the reference arm and the sample arm, either they are exactly synchronized or there is some delay but it's still shorter than the coherence length. At that time the image will be formed and constructive interference will happen. Otherwise there will be cancellation of these impulses and there will be no image formation. Now this is very important. Why? Because by this way we will have what's known as the optical biopsy of the structure. So we convert the slide to we don't just take an image of the structure, but we take an optical biopsy. This is called an image resolved or depth resolved image. Depth resolved image means that we have a high resolution for each layer of the structure. So we have detailed visualization of the endothelium, detailed visualization of the stroma, detailed visualization of the pomus membrane, the epithelium, and so on. So this is a depth resolved image. Based on this coherence length, you see, this is the coherence length between 2 to 15 microns. So the A scan that is propagated from the machine. Now, as you can see here, this is the cornea. So the impulses will be propagated or reflected back from the epithelium, from the stroma, from the endothelium, and will be reflected as an A scan, like in the ultrasound. So the intensity of this reflection will be reflected in this way. This is for the epithelium, and this is for the stroma, and this is for the endothelium. This is the A scan. Now for the B scan that we are seeing in the image is two-dimensional, is made up of thousands of these A scans. We will speak about them later. These thousands of A scans will form the two-dimensional, very fine, beautiful, histological-like structure of the cornea or the retina, which we see by B scan. That's the B scan, which is made up of plenty of A scans. So this is the basic principles of the OCT. I need you to memorize this. The OCT uses a low coherence light. This coherence light, actually, this is an advantage. The presence of low coherence here, this pulses or burst, is advantage, is not a disadvantage. Because if you use a standard light with continuous pulses like this, now what will happen? Each layer of the structure that we are sampling, they will reflected back, the impulses will be reflected back at the same time. And when they are reflected back at the same time, they will reach all at the same time to the detector, and there will be a blur, there will be a noise, so there will be no image formation. However, the presence of this low coherence make us easy to have an idea about each layer separately based on the refractive index of the material. So you will have details about the epithelium, because the epithelium has a special refractive index, then the pomus membrane has special refractive index, and then the stroma and the dismus membrane, and so on. So based on this low coherence, we are able to have an optical sectioning of the cornea or optical sectioning of the retina and whatever. So this is the basic principles. I hope it is easy for you and easy to understand. Now, after we understand how the image is generated in the detector of the OCT, once the signal is created for the image, now this signal will be propagating to the computer for the display. Now we will speak about the display, how you will see this image. As you know, we have the three types of presentations: the A scan, we have the B scan, and we have the C scan, and then finally we have the MFAS block. Now, the A scan is the first building block for all these images. The A scan is very important. Now, the A scan represent what? Represent the time delay of the receiving the reflected back rays. So it gives you an information about the depth of the structure, so that, for example, you can see here the deflection here from the nerve fiber layer. However, the deflection here from the retinal pigment epithelium. So why this lag between them? Because this is lies anteriorly and this is lies posteriorly. So the only information that we gain from the A scan is just gives you an information about the depth of the structure that you are taking the picture, and also the reflectivity. You can see the amplitude of this impulse is representing the reflectivity of the tissues. So the A scan is similar to the ultrasound. That's why it is named also sometimes echo, because it is similar to the A scan. It is one directional image taking horizontally along the surface of the retina, and it represent only the reflectivity of the tissue based on its inherent property, and also based on the depth of the tissue. Now, there is no much information, as you can see from the A scan, so that if we collect this A scan in a vertical array along the XY axis, all these thousands of A scans will provide us the B scan. The B scan is more brighter and two-dimensional image. It is made up of thousands of the A scans. I think if we take bigger picture, for example, you can see here. So this is the B scan, is made up of thousands of A scans. You can see the vertical sectioning of the retina. This is called optical sectioning or vertical sectioning of the retina, or sometimes named as slices. This is the retinal slice, okay, from an anterior to posterior. So you can see the details more based on the reflectivity, and you can see the different layers can be seen. Now, to have more information, you can see that the B scan will give you about the pathology, but you cannot know which part of the retina is this pathology is present. So it is present in the anterior posterior location, but you cannot determine the pattern or the depth of these lesions, or the how extent the lesion is inside the retina. So you need a three-dimensional picture. Now this comes the C scan. Now the C scan, this is a three-dimensional volumetric data which is gained from plenty of B scans. Now if we gather plenty of B scans, this is known as the raster scanning, because they are vertically or horizontally parallel to each other. So this gives you a volumetric data of information in a three dimensions. And now we name this as geometric scanning. Geometric scanning. The C scan actually is not used in the OCT as a term per se. It is mainly used in physics, because it is very sharp horizontal cut at a particular level. However, in the OCT, the software make a modification respecting the concavity of the posterior pole. You can see the concavity, so this is named as MFAS sectioning, or it is anatomical slab. So in the C scan, it is a three-dimensional data informations, but taking horizontally in exact level. So it is not suitable for the eye. It is used in the physics more than in the eye. But in the eye, to respect the posterior concavity, so that the cut will come through a complete layer of the particular layer of the retina, so that the cut will come through the retinal nerve fiber layer, or through the retinal pigment epithelium, or the Bruch's membrane. If we take a straight cut in a curved structure like this, now you will find area here from the nerve fiber layer, then you will find another area from the retinal pigment epithelium, then another area from Bruch's membrane, for example. That's why it is not used in ophthalmology. Why? Because the concavity of the posterior surface of the cornea, of the retina. So you can see the sequential display that can be presented using the OCT from the echoes here to the horizontal or optical sectioning along the X and Y, three-dimensional volumetric block. This is called geometric presentation. This is called geographic representation. Geographic representation, the emphasis. This presentation commonly used in the OCT angio because we wanted to separate the superficial retinal plexus from the intermediate retinal plexus and deep retinal plexus. So we use this geographical representation also in geographical corneal dystrophy. Okay, so this is the different displays. Similarly here, you can see this is the two-dimensional display of the B-scan. And this is the A-scan, as I say. This is the building block for all of what we are seeing now. And this is the three-dimensional C-scan, the building block. As I say here, this is modified so that it becomes an in-face slab. For this three-dimensional, we say this is the slab. When you hear the slab, it means that it is three-dimensional volumetric data. And when you see the B-scan with his named as a slice, and the B-scan is known as a slice. Okay. So this is very clear image. So this is the best thing that we can gain from the OCT during the display. So you can have detailed information. As I said, that the B-scan gives you, for example, it gives you a pathology here, but you don't know how much the extent of this pathology within the retina. Is it just this at this level, or it is beyond this one? That's why this comes the importance of the three-dimensional in-face slab for determining the pattern and the extension of the pathology inside the retina. Now, after we finish the image generation and image display, we come to the final part of the basic principle or the physical optics of the OCT, which is an important terms that we should know and know the difference between them, which is known as the axial resolution of the OCT and the lateral resolution and the scan depth or the penetration. All these terms should be well known so that we understand the relationship between resolution and penetration, which are the fundamental principles of the OCT, and their relation with the wavelength or the band width. So this is very important slides. Now we come to one of the important parameters or the specifications of the OCT, which is the axial resolution. The axial resolution means the resolution that you can see by sectioning the sample from anterior to posterior, either the cornea or the retina, so that you can see the fine details of each layers in a microscopic level. So the equation of the axial resolutions, as you can see here, there are two important parameters. That's the wavelength of the light source as well as the bandwidth. And we used to say that the axial resolution is a function of the bandwidth. The more you increase the bandwidth, the more you will have a very fine axial resolution, because this figure will be very small. Now this equation means that if you increase this figure, the number here will be small. Smaller number here indicate more axial resolution. It is the reverse. Why? Because this figure represents the size of the section that you are going to take through the cornea or the retina. The smaller the section that you take, it means that you will provide a very high resolution. Now, if we apply this in the spectral domain OCT, as you can see here, we have a wavelength of 840 nanometer, and we have a bandwidth of 50 nanometer. So by applying this to these equations, we will have a final figure which is 6.2 micrometer, which is below 10 micrometers. So this is a microscopic level of resolution. So this is regarded one of the best resolutions so far available in the market. Now, if we leave this for a while and we come to the ultra high resolution OCT, see what happens here. We have the same wavelength. We fix the same wavelength, but we doubled the bandwidth. Now we make the bandwidth 200. So we achieve a very, very fine resolution of 1.4 by decreasing this number. So this is why it is named as ultra high resolution. So let's fix this very clearly for you, that the more the bandwidth, the more will be your fine axial resolution. Now, what happens if we increase the wavelength here, as happens in the swept source OCT? Now in swept source OCT, we increase the wavelength. Instead of 840, we make it 1310. So by increasing this wavelength, the bandwidth, we have to increase the bandwidth to cope with the much duplication here of the wavelength. So what happens? Although we have increased the bandwidth to 100 nanometer, but still this is not enough to bring down the final result of this equation to a figure lesser than 6.2. That's why it gives us 7.5. Now let's explain why this happens. Now, the wavelength is a function of the penetration. Now, in the swept source OCT, we need to have a very good penetration to the opaque structures, as I said before, to the sclera and to the iris to have more fine details. So at that time, we increase the wavelength. But this increase in the wavelength has brought down the resolution to a bigger figure so that the resolution becomes poorer here. But we have to sacrifice for some degree of resolution for the sake of increasing the penetration. That's why we should say that there is no an ideal OCT that is very high resolution, very high penetration for all structures of the eye. This is theoretically possible, but practically is not there. So we have to determine and to choose the OCT based on your need, in what specialty or what structure you are going to use. So in the spectral domain OCT, we have a very good penetrations. Also, we have a reasonable resolution, but not comparable to the spectral domain and not comparable to the ultra high resolution. Now, for ultra high resolution, we have limited penetration also in the spectral domain, but we have very fine high resolution and very fine details. So in general, as long as the resolution below 10, this is a microscopic level, so it is good for viewing the different structures and layering of the cornea and the retina. Okay. Now, if we look to this slide, what I want to say here that there is another term apart from the axial resolution. As I said, the axial resolution is when you take the scanning of the section along the z-axis, from anterior to posterior, so that you want to find the fine details of each structure. Now, the axial resolution is dependent on the quality of your light source. As I said, low coherence, the bandwidth, so it is dependent on the light source and is not dependent on the optics or the physics of the machine itself or the patient's eye himself. So it is purely dependent on the light source that you are using. However, the lateral resolution is the resolution of the image that you see along the XY axis, like the picture of the fundus that you can see. All of us have notes that when you look to the B scan of the retina, you will find very fine details for each layers from the retinal nerve fiber layer up to the retinal pigment epithelium. This is because of the axial resolution is high. But all of us, we see that when we look to the fundus picture, the fundus picture is not as sharp as the axial or as the B scan of the retina. And the reason why, because the lateral resolution is less as compared to the axial resolution. The lateral resolution in the OCT is less as compared to the axial resolution. And the reason why, the lateral resolution is not dependent on the light source, is not dependent on the bandwidth, but it is dependent on the optics of the machine you are using and also in the patient's refractive state and the optical media. For example, if there is corneal opacity or medial opacities or patient high myopia, all this will affect the lateral resolution but will not affect the axial resolution. However, the lateral resolution also, it has usually we used to say in ordinary optics or any camera that there is inverse relationship between the axial resolution and the lateral resolution, that if you have a high axial resolution you will have poor lateral resolution. But the OCT break down this relationship. We will explain in the next coming slides how the OCT break this rule. That's why there is no more inverse relationship between the axial resolution and the lateral resolution, because the factors affecting the axial resolution is totally different than the factors affecting the lateral resolution in OCT. That's why there's a question why in modern OCT features we have incredible axial resolution of 5 micrometers, but vastly we have inferior lateral resolution reaching up to 15 to 20 microns. So the lateral resolution we have 15 to 20 microns, which is very much poor as compared to the axial resolution. In the coming slides, I will decode the meaning of lateral resolution, and then we will understand why the lateral resolution is poor in the OCT as compared to the axial resolution. Now we come to the second important parameter regarding the specification of the OCT, which is known as the lateral or transverse resolution. We've spoken about the axial resolution, and we say that the axial resolution represents the anterior-posterior resolution of the layers of the retina, and the ability to discriminate between different layers that lies coaxial with the light source or the imaging beam. However, in the lateral resolution, we mean by the lateral resolution the ability to discriminate between two adjacent points. So it is along the XY axis. However, the axial resolution along the Z axis. So simply to understand this, that the axial resolution is exactly like the power of the convincing lens. When we say that the power of the lens is so strong or so weak, we mean the axial resolution. However, the lateral resolution means the field. When we say that when you increase the power of the lens, you will have limited field because there will be a reduction of the field. So exactly it is the same, the lateral or the transverse resolution. So if you have high axial resolution for the lens, you will have limited visual field. That's the lateral resolution for that lens. This is applicable for any optical system like indirect thermoscope or slit lamp or whatever. But here in the OCT, the idea is completely different. We'll explain later on about the disengagement between this axial resolution and lateral resolution, but just keep in mind that the axial resolution represent the anterior-posterior ability to discriminate between points that lies coaxial with the examining beam. However, the lateral resolution is the ability to discriminate between the 2 points that rise perpendicular to the examining beam. Now these points lies perpendicular to the examining beam. However, the axial resolution, there is one here and one behind it, so they are coaxial with the examining beam. Any OCT machine, you will find very high axial resolution, but you will find limited lateral resolution. For example, the axial resolution is 5 to 6 microns, which is very high. However, the lateral resolution is 15 to 60. That's why in any image you find it, you will find what's known as anisotropic resolution. This is named anisotropic resolution. What's meant by anisotropic resolution? That the axial resolution is more than the transverse resolution, so the image will be very sharp in the Z axis, but is a little bit blurred in the XY axis. This is very clear. So I might ask you, what do you mean by anisotropic resolution? This is because the axial resolution is more than the lateral resolution. In the next slides, we'll speak more in details about the physics of the lateral or transverse resolution. Again, here we are still speaking about the lateral resolution, and as I have said earlier, that the factors affecting or governing the lateral resolution is not related to the factors governing the axial resolution. It's completely different. The lateral resolution represents the field of view that you can see at the same time in the cornea or in the retina. So it is dependent on the power of the condensing lens in the optical system, dependent on the size of the light source, the spot size, and also related to the refraction of the patient, if he's myope or hypermetropes, and all the optics of the patients like refraction and diffraction and so on. That's why there is no relationship between the axial resolution and lateral resolution in OCT. And this is very important because in other optical systems, for example, in the indirect thermoscope or in the slit lamp, if the axial resolution get increased, the lateral resolution will get decreased because both factors governing the axial and lateral resolution are the same in that systems. But in the OCT, no, there is no correlation between the axial resolution and the lateral resolution. So you can see here the axial resolution is very fine, very superior here, around 1.4 to 7.4 microns. However, the lateral resolution is inferior, is 15 to 20 microns. And this explains why in the in-fast block, when we see the retina in along the XY axis, the retina is not clear as compared to the section that's taken through the axial resolution. Now, in the next picture, I will explain you, for example, this is the cornea, and if we have to see, the cornea is curved, is not a straight line, it is curved. Similarly, the retina is curved. So if you want to have a spontaneous view of large area of around 10 millimeter from the cornea or the retina, so you need to have a low lateral resolution, little bit, so that you can have large depth of focus. This is the depth of focus. It means that you will have a clear view of all of these points at the same time. You need not to adjust your focus to have a sharp image. Why? Because you have limited or reduced the lateral resolution. So we sacrifice for some clarity of the image in the lateral resolution for the sake to increase the depth of focus, the depth of focus. For example, now if you can see here, if we are looking to the retina, if we make the lateral resolution very high, so you will see a very small spot of the retina very sharp, but the rest of the retina will be very blurred. However, we defocus this focus a little bit so that we can see a large area of the retina with a reasonable view, and we can see the 500 micron sliders of the retina without the need for fine adjustment of the machine. Also, we can overcome the microsaccadic movement of the patient's eye, so that because we have enough depth of focus. Now, this depth of focus will overcome the microsaccadic movement of the patient's eye. So this is very important. So the lateral resolution, we sacrifice for some clarity in the lateral resolution for the sake of viewing large panoramic area of the cornea and the retina without the need for fine tuning, as well as increase the depth of focus so that we can see all the layers with reasonable resolution. That's why in the manufacturing companies, they achieve what's known as the sweet spot. What's this spot size of light that can provide a reasonable area to be seen in the retina or the cornea with reasonable resolution? This is called the sweet spot. So we cannot go for very high resolution, the lateral resolution as compared to the axial resolution, but 10 to 30 micro resolution in the transverse or lateral resolution is sufficient to view a large area of the cornea and large area of the retina. This is a practical or real example. You can see here, this is due to the axial resolution. You can see the sharp details of layers of the retina because this is based or dependent on the axial resolution, which is around 4 to 7 microns. However, when you see the in-face image, this is the in-face image, it is not as sharp as this one, and this is because of the lateral resolution. Now, to have this size of a view, you need to reduce the lateral resolution to have this size. If we increase the lateral resolution, what will happen? You will see only very small spot here. Similarly here, this is the picture. So you can see the image here in the in-face view is blurred, is not as sharp as is in this one. Another point that I would like to add it before I forget, that because the axial resolution is very high, and the axial resolution is the resolution along the anterior posterior axis in this one, in the Z-axis. And the lateral resolution is the resolution along the X and Y axis. So as if the image, when you have this image, this is elongated and anterior posterior like this, as if you catch this image and pull it there. So what will happen? The image will be pulled in this direction, but will not be pulled in this direction. And what's the result of this? This will make the image, especially for the in-face block, more blurred. Another thing, the depression of the fovea, the foveal bit here that you see here, it will appear larger than what's normally. Normally, the foveal bits or depression is smaller than this. But this is because the axial resolution is higher than the lateral resolution. So you see this very acute depression in the fovea, as if it is very deep, but actually normally this is not due to the deep length of the foveal bit, but because of the axial resolution is much more than the lateral or transverse resolution. So the image appears as if it is pulled vertically like this. So if I ask you in the exam why the in-face image is blurred as compared to the section B scan or the B section of the retina, the reason that the B scan is mainly dependent on the axial resolution, so a very fine details can be seen. The resolution here between 4 to 7 microns. However, in the in-face picture of the fundus, the resolution based air in the lateral or transverse resolution, which is around between 15 to 20 microns. Now we come to another important and third variable in the understanding of the basic principles of the OCT, apart from the resolution, the axial and the lateral resolution, is the penetration, the tissue penetration or the image depth. This is very important to select which wavelength you will use for proper structure. For example, if you want to image the ciliary body or scleral spur, you have to use a sufficient amount of wavelength to provide a good penetration for the structure. So the definition is defined by the actual depth in tissue that can be imaged, and this is limited by the light scattering and the absorption. As we explain here, you can see this is the rays or the impulses which is going inside. This will be affected by the absorption of the tissue property itself and by the scattering rays. Then the ray will be decayed and there will be noise, there will be image here. So these are very important factors, is the absorption and the scattering by the tissue. So the three important factors affecting the image depth, keep it in your mind: the wavelength, not the bandwidth. The bandwidth, we've spoken about this before in the axial resolution, but for the image penetration or deep penetration, we need longer wavelength. Other variables is the tissue property and the tissue system sensitivity, means the computer system connected to the OCT and its ability to resolve the tissues. For example, you can see here the penetration for at an 840 nanometer for the cornea is about 2 to 3 millimeters. However, when we increase the wavelength, the penetration is more 4 to 6 millimeters, and for the sclera around 3 to 4 millimeters. That's why the swept source OCT using this wavelength is suitable for studying the sclera as well as the ciliary body and scleral spur. Now, as I said, the important variables affecting the penetration is the wavelength. The more the wavelength, the more the penetration, the tissue property and the scattering property of the tissue, and also the sensitivity of the system and the ability of the computer to resolve the image. Now, if you can see here, if we keep the tissue constant, so that we apply different wavelengths for the same tissue, that's the cornea, you can see here, once we increase the wavelength from 840 to 1310, the penetration increases from 2 to 3 to 4 to 6 millimeter. So provided the same tissue, but we increase the wavelength. So the more the wavelength, the more the penetration. Now in this experiment, if we provide the same wavelength, but we have different tissues, this is the cornea and this is the sclera, you can see that the penetration in the cornea is more and to the sclera is less, and this is related to the tissue properties. So this is two important variables determining the penetration and the image depth. Now I want you to understand this term, which is the OCT paradox. Now, as you know, that the word paradox means that there is some controversy in one aspect with other aspect. So there is some points in the OCT that if you are willing to have a very high resolution, this cannot be attained with high penetration at the same time. So this is the paradox of the OCT, and this is due to some physical barriers. So in the next discussion, we'll speak briefly why we cannot have a ideal super OCT that can have maximum axial resolution with deep penetration and super lateral resolution. Some points we have discussed before, but just here I would to highlight that this is a theoretical suggestion that the ideal OCT, like a theoretical car, that race car that you construct and design it in the paper, but when you go in the reality, it is stuck with the physical barrier, so it will not achieve what you have drawn for it. So the same thing for the OCT. This is a very impossible mission to have a very high speed with very high resolution and very high penetration at the same time. So as you can see here in this knock, you have to choose either to go in this direction or to go in this direction, and we will explain based on what that you choose a very high resolution or you choose the penetration based on your need for the patient, what type of image that you want to do. So this is the maximum levels that we are targeting to achieve high resolution of 1 microns with very high penetration of 25 millimeter. That's involve the whole eye simultaneously, but this goal is still impossible till now. So this is the ideal, as I said, that if you reach to a 1050 nanometer wavelength, this will be provide total penetration for the whole eye. And if you have a bandwidth of 200 nanometer, you will have very super resolution. And if you use the swept source OCT with maximum speed, this will provide very high rapid scanning with zero blurring of the image, because this will overcome the microseconds, as I say, of the movement of the patients. And also this will cope with the speed of red blood corpuscles and the blood vessels of the retina, so that you can do also angiography for the retina. But this goal, as I said, this is not attained so far and will not be attained for the soon, because this is stuck with the physical barriers that they cannot be achieved together. And this is what's meant by the OCT paradox. So as I said, the reason why that if you have very high resolution, if you want to have a high resolution, you will need to use a very long wavelength, and the maximum wavelength that can be absorbed by the eye, the vitreous and the aqueous, is 1500. And if a total absorption happens, this will create a temperature, a high temperature inside the eye, and this will be against the safety rules and boundaries made by the ANSI regulation for the use of the laser beam inside the eye. So you cannot use 1500 wavelength of the laser beam. This will create high temperature inside the eye. Same thing for the penetrations. If you have very high wavelength, due to the total absorption, there will be zero penetration, so you cannot have picture for any of the structures inside the eye. So what's the solution? Now the solution is that you have to match the physics that you have based on the tissue that you want to have a picture. If you want to have a picture for the cornea, so you have to use a very high resolution so that you see the whole layers. You don't need too much penetration here. If you want to visualize the ciliary body or the angle, so you need a good penetration at that time, you have to sacrifice for some resolution for the sake of the penetration. If you want to have to visualize the retina, you need a very good penetration and size, so you'll sacrifice for some of the resolution. So this is known as a trade-off. Based on your needs, you choose this button in this direction or in this direction. Okay, so whether you are using it for a specialty, cornea clinic, glaucoma clinic, or retina clinic, so you can choose and select which one is appropriate for your imaging. Still in the context of evolution of this technology, and one of the major milestones in the evolution of this technology is the use of multimodal synergy. By multimodal synergy, we means that we use a hybrid system that utilizes two technologies in the same time, utilizing the advantage of this technology and overcome the drawback of the other technology. For example, you combine a Placido's disc system with a OCT, that's interference system, or the use of sham flock technology along with OCT. So the combination, this combination is very important, make a synergistic effect, and this integration is very useful, and this is the future for this technology, is the integration. For example, when we utilize the reflection based system, as you know, the reflection based system is very superior in mapping the anterior surface of the cornea, because it is based on the mirror effect of the cornea and the spectral reflection. However, some drawbacks of this reflection system, that is the problem of the dryness and what's known as the air tear film interface. So if there is any dryness of the cornea, this might give unreliable results, and especially if there is some irregularities of the surface of the cornea. So now when we do combination of the reflection based system with OCT that has good subsurfacing anatomy and very high resolution, we can overcome to some extent. And the most important is that the data gathered by this combination is much more reliable than using the single technology alone. As you can see, this is the M39, utilizes the Placido's based system with the Spectral-Domain OCT. So this is one of the gold standard in the measurements or the imaging of the cornea. Similarly, when we use the sham flow technology. Technology provide a rotating camera that provides three-dimensional mapping and provide a global view for the anterior chamber, but it will not provide details for the angle structures. And also it has a problem with the resolution. The resolution of the sham flow technology or the pentacam is around 50 microns as compared to the resolution of the OCT, which reaches up to 5 microns. So by combining the sham flow technology with the spectral domain OCT, for example, this is the pentacam or anterior segment OCT. This is a combination of spectral domain along with the sham flow technology. So we will overcome all these problems. So we'll have very good details and determination of the elevations on the surface of the cornea, very good information on the posterior surface of the cornea, and very high resolution reaching up to 1.9 axial resolution, which is this is to a microscopic level. So we will see a very good details for the cornea. Each lamellae and each layer of the cornea can be seen with very high resolution. So this is the future for the corneal imaging, is the use of this combination so that we can have a synergistic effect. Synergistic effects means that not 1 + 1 = 2, but 1 + 1 = 2, more than 2. Similarly, as I mentioned here, the Placido's disc has a superior resolution for the anterior surface. However, the other systems less, because the Placido is based on the reflection from the anterior surface of the cornea, which is transparent. However, the other systems, which is the scattering system, the sham flow technology, based on the backscatter. So if you have a transparent cornea with high reflection, so the scattering will not be that efficient from the anterior surface. That's why for mapping the anterior surface, we have to combine it with the reflection base. So this is an example of combination of reflection with scattering and sham flow technology. However, the utmost combination, the use of OCT, will provide very good details for anterior surface, the subsurface structures like the stroma, very high resolution, also very good informations about the posterior surface. And it is not just only the visualization, that's the resolution, but also the reliability of the data. So we have two important variables. We have to have a reliable data, as well as we have to have a very clear data. So this is now the gold standard for screening for keratoconus or for imaging of the angle structure, detailed trabecular structures, is the combination technology. One of the important integration in the market, as you know, the use of MS39, which also promote the ray tracing calculation, because we improve the data gathered from the surface using the Placido's disc. And if there is any artifacts or abnormalities in the anterior surface tear film, especially the tear film, the use of the high resolution anterior segment OCT will improve the ray tracing, and this also will impact the IOL calculation. So this combination, one of the dual systems that's available in the market, that enhances the data acquisition using the combination technology. So this is one of the famous examples. Another example, as I spoken before, is the use of pentacam anterior segment OCT, which is now the gold standard for any screening for refractive surgery or for keratoconus. So this is the pentacam OCT. As I said, now this is the gold standard for screening for the keratoconus and the refractive surgery. The sham flow technology will provide general information about the geometry and the anterior chamber depth. However, no details on the angle. So the details of the angle is gathered by the incorporation of the spectral domain OCT that provide ultra high resolution, reaching up to 1.9 micron resolution, so that you can see the cornea up to the microscopic level. So the fine details in the stroma you can see, also the undulation here in the Bowman's membrane. So this is very incredible information that's make this technology or this combination synergistic combination. So the final statement that the future is for this combination technology, and nowadays also they integrate or they incorporate the use of anterior the AI, that's the artificial intelligence, along with these systems for pattern detection and recognition. And we jump from the just detection of the disease to the prediction of the disease. So this is now the gold standard for the future multimodal integrated imaging system. Now we reach to the final section of our lecture regarding the future prospect of this emerging, evolving technology of the anterior segment that reaching to the high level of resolution, reaching to the level of digital histology and clinical biopsy. So the question arises, is there any future for the slit lamp? I make a title for this slide that it might be the sunset of the slit lamp by the year 2050. In view of the huge advancement in the anterior segment OCT and the digitalization and the integration of the AI, and also nowadays the spoken about the spectral anterior segment OCT, so that it will color each and every layer of the cornea, so that instead of you are seeing a grayscale colored map, you will see it in colored and with the true colors and pseudo colors. So this will bring the question, is there still any role for the slit lamp in the future or not, or should we keep the slit lamp in the museum? Now, there are three important questions I will discuss about this very briefly for you, that perhaps is there still any role for the slit lamp, or we should keep it in the museum in the future, or how many of us feel that 50% of our slit lamp finding are purely subjective, so that we no more dependent on subjective impression, because for example you can see any pathology in the cornea, you feel that this is, for example, feathery appearance, other one will see that no, this is not feathery appearance, and so on. So most of the information that we gather using the slit lamp are subjective information, although it is based on our experience, but the learning curve for this experience is different from subject to subject. So we might need an objective information using the OCT more than the subjective information that we gather from the use of the slit lamp. Another question, does the transition from this qualitative observation to the quantitative tomography, as I mentioned now, to the optical or digital histology, is there still any role for the doctors in the medical health for the patient or medical care for the patients? I will discuss briefly in these topics, though they are interesting topics. You might be asked about this in the exam, just for scrolling your mind and find out what's your thought about these ideas. Now, to answer the previous questions, we will go quickly through the evolution over nearly 1 century from the beginning of the slit lamp at 1911 till the onset of the anterior segment OCT, so nearly 1 century elapsed. So that we reach to this advanced technology and the future prospect for the possibility of portable anterior segment OCT with spectral pictures and pseudo color presentation and display for the structures is seen. So we will go quickly to the advantages and disadvantages of the slit lamp. You can see that the slit lamp, one of the disadvantages that need close proximity to the patient, nearly to the contact of the patients, and the data usually subjective and depends on the patients and the user himself, and usually qualitative data. And the image, when you look to the cornea, you will not see it in colored scale, it will be in a gray scale, and all the informations are static. However, when you look to the prospect for the anterior segment OCT, it is non-contact, so it will be portable in the future, and also with the integration of the AI, the information becomes more quantitative, so that you can follow up your patient based on fixed data stored in the machine, and you will see the improvement. For example, in case of uveitis, when we use the slit lamp, we used to scale the activity +1, +2, +3, like this, based on the subjective interaction of the examiner. However, in the OCT, you can do objective way of scaling of the severity of uveitis, and you follow up your patient whether he improves or not. Similarly, if in the presence of corneal ulcer and the determination of the healing process, you can examine by slit lamp and subjectively follow up your patient, but this is not an accurate way. So by the use of the OCT, so you will provide more objective way of following of your patient. So we are transferring, there is a transition from subjective human observation to an AI quantified biochemical data, and also the future for the colored scales, either pseudo colors or real colors for the structure that's seen by the OCT. So as you can see that there is a paradigm shift in the observation and what's named as digital histology or clinical biopsy. So exactly like what we are in this area, and you are going to be in this era. By the slit lamp, you can see the cornea with just a grayscale. However, in the future, it will be colored and will be very elegant like that one. But now, similarly here, this is just the proposal for what would be the normal architecture of the cornea using the anterior segment OCT, the color of the epithelium, stroma, and different layers. And when there is any pathology of the cornea, it will appear like this. So this is a huge evolution in the diagnosis of corneal diseases using the anterior segment OCT. Now the question that arises, does this mean that we are going to forget and keep the slit lamp in the museum? The answer is not. There are certain advantages of the slit lamp. One of them is the true visualization, that you are dealing with a true visualization. The structure that you are seeing is a true structures, unlike when you are dealing with the image in the OCT. The other thing is the live manipulation, that you can manipulate your patients while you are examining the slit lamp. For example, when you want to do the Seidels test, you will apply the fluorescein to the patients and you press on the eye so that you will see the river appearance of the fluorescein. So this maneuver cannot be done with the use of the OCT. Another thing is the stereoscopic real life visualization. You are seeing your patient stereoscopically with 3 dimensions, which is not the state on the OCT. So I think, or most of the experts think that the future for the OCT will be not that we neglect or forget the OCT. I mean the future for the slit lamp, that we will not forget the slit lamp, because it will remains the gold standard for any basic eye examination. But there will be augmentation for this slit lamp. There will be enhancement of this slit lamp by the integration of the OCT in the slit lamp like this. So there will be a slit lamp integrated with an OCT, so that you will have both subjective evaluation as well as objective evaluation. When you need any objective evaluation, you will use the OCT, but sometimes you need your integration and you need your subjective evaluation, so that the role of the doctor will be still there. So but there will be no forget for the slit lamp. There will be augmentation for the role of the slit lamp by the integration of the OCT and also the integration of the AI. So the image will be integrated by the AI as well. Now, in completion, for the last question regarding, is there still role for the doctors in the view of this huge evolution in the imaging technology? Is there still role for the doctor? As you can see that the degree of resolution using the anterior segment OCT and the high definition imaging reaching to the what's known as digital biopsy and clinical biopsy or digital histology help us to large extent to view and to bypass the physical barriers to see underlying structures and see the details of the subsurface structures. But this will not replace the skills and the professions of the doctors. You should keep this in mind. Although this technology has improved our diagnosis, but the intervention is still by our hands. So this is the answer for the question that is there still a role for doctors or not? Yes, because the doctor, he's the one who will determine the intervention for the patients, the one who will integrate all these information in view of the socioeconomic state of the patients and the affection of his lifestyle, and then decide what type of intervention is suitable for that patient. So my advice to you, that don't be panicked that you will lose your job. No, but my advice for you that be relevant. Be relevant means that يعني خلي لك عازة في المستقبل. يعني بمعنى انك لازم you should utilize the AI and the huge advancement in this technology to improve your skills especially in the surgical field, so that even if they don't need your help in the diagnosis, because everything will be automated, they will need your help because of the surgical intervention. So my advice to you, be relevant. Now by this level we reach to the end of the first session. And as we conclude in our technical discussion on the physics and the clinical application, the next lecture will be the clinical application of OCT. I want to leave you with the final thought that beyond the data that we are seeing on the screen of the OCT machine, we spend much of our time analyzing the axial resolution and the signal strength and also the layer segmentations, but we must remember that these tools are not the end goal. Our goal is to provide and dedicate to provide insight for our patients and to preserve their vision. So the next lecture will be about the clinical applications, so that all this information that we have just gained in this lecture, we will try to apply them in the next session, which is about the clinical application of the anterior segment OCT. Thank you very much for your dedication, for the insight, for your patience, and looking forward to meet you soon. And as I used to say, please contact me for any verification or justification for any points. Thank you very much.